Welcome everyone. My name is Sarah Morrison and I'm with Foothold Technology. Thank you for joining us on today's webinar, Navigating the World of Medicaid for Supportive Housing. We have quite a bit of information to get through today, but would like to answer as many questions as possible. If you have a question at any point during the webinar, please send a chat message to Foothold Technology. We've left a few minutes at the end of the presentation for Q&A. And now let me introduce two members of the Foothold team who will be guiding today's webinar. First, we have David Bucciferro, our Senior Advisor. David joined Foothold Technology after more than 25 years at the New York State Office of Mental Health, most recently serving as the Director of the Rehabilitation Services Unit. He brings a visionary yet practical insight into program development, budgeting, performance management, and compliance called from a distinguished career in mental health services. Secondly, we have Paul Rossi, who's our Director of Client Services. Prior to joining Foothold Technology in 2001, Paul spent more than 10 years in Los Angeles providing direct client services to the homeless and those living with HIV and AIDS, as well as serving as the Director of Programs for the Los Angeles Homeless Services Authority. And now I'm going to pass it over to David and Paul.
Hi, everybody. We're excited to have you join us today to talk about supportive housing and the role that Medicaid is playing in covering costs for this important housing model. For providers in the supportive housing arena, it's no secret that the road to recovery begins with housing. However, it's not always been recognized by major healthcare entities like Medicaid. So thankfully, the mindset's been changing, and now with housing being recognized as a social determinant of health, we're seeing more collaboration across healthcare providers and housing providers in many communities, and even more importantly, we're seeing Medicaid sharing in the cost for supporting residents in supportive housing. David and I sat down with some representatives from different communities to talk about which models of supportive housing are in our communities, how funding sources for services have changed, and how the introduction of Medicaid in the supportive housing arena has changed the way organizations document and provide services to their residents. So David spoke first with Steve Coe, who's the Chief Executive Officer of Community Access in New York City. Founded in 1974, Community Access is a pioneer of supportive housing and social services in New York City for people with mental health concerns. Let's listen to what they had to say.
Steve, is there a current funding model for supportive housing, either with the way you operate or in New York State?
So there's two flavors. There's New York City, and then there's the rest of the state. And New York City, the state and the city have developed an agreement in 1990 to jointly fund rent subsidies and support services in supportive housing. And so those are all contract dollars, and they support usually a program director and maybe 2 or 3 staff on site and front desk service and so forth. And the rest of the state, they don't have that level of funding, the richness of funding. They'll patch together different contract funds from city and state agencies, sometimes local agencies, fewer services, and maybe they go without the front desk. The Office of Mental Health also will fund support services both in the city and the rest of the state. That's a pretty stable funding model.
Thanks, Steve. So what has been your experience, including any hopes and fears you may have had or have, with the transition from state grants into a more federal funded model, in particular as they talk about moving more towards a Medicaid program for supportive housing?
So there's not really many upsides. This began in New York in 1993, where we had contract dollars for all those transitional housing units, and in order to capture federal dollars, the state set up this Medicaid reimbursement and imposed several new requirements on agencies. Services had to be delivered from a list of 14 different services. They had to be delivered 4 times during the month. They couldn't be delivered on the same day. If somebody needed 8 services, that would be too bad. If somebody needed 1 service, that's too bad. Then you don't get paid, for the full rate. So the incentives for the agency to deliver services in the way they're needed is greatly undermined under a Medicaid model. I think they greatly underestimate the amount of administrative work it takes to bill. The risk to the agency is that you deliver the services and you think you've documented everything correctly, but an audit will reveal that a particular service wasn't documented correctly, and there can be a take back. We've had issues here where a staff member falls behind in work and then might start to fudge the documentation. We find out about it. We have to take action with the staff person, and then we also have to report. The documentation for this billing is not correct, and so that's sort of a self-report. Then you're liable for the take back for that. So there's no there's no really way to sort of get ahead, I would say. The Medicaid funding works great for the state because it offsets some of their costs. It doesn't really offset, at least the way it's been set up in New York, the provider costs. The trend now also is for us to move not just billing the state directly through a contract agency. They use Computer Sciences Corporation, processes all the Medicaid billing. Now we are being asked to identify, as we go to Medicaid managed care, is to identify the Medicaid plan that each participant belongs to and bill the different insurance companies separately. They're supposed to have similar procedures. We've found that their procedures are not the same. So, in our experience with the respite center, we're only getting paid so far from one company out of the 6 different companies that we've, been trying to establish relationships with. The same thing with we have a PROS program, which you're very familiar with, clinic type program. Again, it was one Medicaid billing, center to the state, and that a year and a half ago it shifted over to we were billing different companies. So it creates a great deal of administrative. So now we have full-time people that I didn't have before. I have 2 full-time people working here who this is all they do is billing. Cash flow is disrupted. Payments, they have 45 days to pay. Sometimes you don't get paid for 6 months or 9 months. So the Medicaid, Medicaid system in New York has created many challenges. I understand in different states there's intermediaries, and the provider agency is not really burdened with all of the administrative tasks for extracting this funding. But it's still the contracts are still the best way to support these services for provider agencies, where you have a set amount of money, when it's going to arrive, you have the flexibility to deliver the services, the amount of services to the right people when they need it, and not be worried that you're not getting all your billable services in. The other thing about Medicaid funding, I think what could work is if you start move to case rates or prepaid programs where you are, you're billing Medicaid, but you're not doing it on a fee for service. Every single encounter has to be billed for. You can collect all the information that you have and send it in one time, and to document the work that you've done and the outcomes that you've achieved. Certainly having an electronic health record, I think part of the subject we're dealing with today, has been invaluable. We had a record system in place in 1993 when the first Medicaid wave came. It was a pretty simple transition into that program and into subsequent revisions, but it's been an invaluable tool, certainly.
Are there additional challenging issues that you've faced, maybe 3 of the most challenging ones that you've had to deal with, Steve, moving into Medicaid? So
just getting all of these relationships established, and when you're billing to one location, you have one person you're dealing with, or 2 people you're dealing with. When you have 6 different companies, it's it's a rotating carousel of characters, and it's not clear within the company who's the decision maker. So the situation I described of trying to establish a billable note that'll generate a payment to us has taken months, and you keep dealing with different people in these companies. So I think the timeline to get these things set up and running it's much longer than like 2 or 3 months. It's like a year-long process to establish this, and you need to be able to test the systems before you go live to make sure that the data you're uploading into their system is meets all of their standards. So that would be one thing. The complications and just the billing itself and needing to hire an outside company to actually process payments for you. So that's an extra cost that nobody is paying for. And I think that the rates don't really reflect the total cost of what it is to do the work. That was one of my big hopes with Medicaid, is that in managed care in general, is that the downside of the contracts is you get a contract and then 10 years later you're getting paid the same amount. With this Medicaid, with the Medicaid approach, it was our hope that we could negotiate with insurance companies and say, this is what we can provide to you, and this is what it will cost, and sort of get paid then a fair price that would cover all the administrative headaches, but also would give us a small surplus at the end of the year that we can use to strengthen our balance sheet. This has cost us cash, so we've had to open a much larger line of credit as a result of cash flow. So you need a line of credit, you need a lot of time, and you need to include costs that you're just hard to imagine before you start doing this.
Is there anything you'd like to add, or?
I don't think so. I think the point I was trying to make before that we are working very closely with all of our colleagues through, I do it both formally through our trade associations, and I do it informally through meetings and conversations. I go look at what other people are doing. We're always sharing ideas, figuring out, who's doing what, and if what they're doing is better than what I'm doing, then I'll change what I'm doing to improve my services. So, and I think that's been the big change in the last 4 or 5 years here in New York. I think we're all feeling like we really need to lean on each other as we move forward.
So as you can tell by listening to Steve, Steve is a wealth of knowledge. He's been an innovator in New York State for many years, and is actually provides a lot of people across the country with ideas and help when asked. A couple of takeaways that I had from things that Steve were talking about. One is the clear administrative burden that Medicaid brings into any kind of system. And coupled with managed care, that creates even a second layer of administrative burden. But the need for preparation and the need to make sure that your systems and your structures are in place are going to be critical. Your billing system, your EHR, your staff training, and just other kinds of controls that you need to have in place to make sure that you're meeting all the standards and regulations. And then the second thing that I take away from some of the things Steve said is that we still have a lot of work to do before we make this an ideal scenario for reimbursing the services of supported housing, and working with governments and managed care companies to ensure that not only the rates are fair and adequate, but that the structures that providers have to go through and the systems that they have to report to and the rules that they have to live by make it feasible for them to be able to provide the kinds of services that are necessary in a way that's not at such a burden on the providers that they just can't do it or afford to do it. So I know that as we go through the rest of the presentations, you're going to feel very similar kinds of thoughts coming forward.
Yeah, David, and I think that Steve's advice about the line of credit, waiting 6 to 9 months for reimbursement for payment of rates that were inadequate in the first place is pretty alarming. So I would imagine that theme will play out through the rest of our conversation today.
Very frightening.
Yeah, so let's go outside New York then. So we also spoke with Lindsay Casale, who's the Housing First Program Director for Pathways Vermont. And Pathways Vermont initially founded in 2009 with funding from SAMHSA, the Substance Abuse and Mental Health Services Administration, to implement Housing First services in Vermont. And here's some of what Lindsay shared about their experiences moving into Medicaid reimbursement for their supportive housing programs. One of the things that we hear people talk about when we hear people talk about Medicaid in supportive housing is that Medicaid itself doesn't pay for the housing, but instead pays for the services. So how do you incorporate Medicaid into the work that you're doing to support residents in their units once you get them housed?
So for us in Vermont, this is actually a relatively new thing. When we first started, we started under a 5-year federal grant through SAMHSA. And this paid for the bulk of the services that we were providing at the time. As we transitioned away from this 5-year grant, we went through a process with our Department of Mental Health to apply to be called a specialized service agency, which allows us to tap into Medicaid funding for our services. So at this time, we're primarily funding our service structure through fee-for-service billing with Medicaid. We also receive some funding through a case rate structure called a CRT, case rate, community rehabilitation and treatment services, for a subset of the population that we're serving under the Department of Mental Health.
And for the folks that get served under the CRT or even under fee-for-service, they all need to be Medicaid eligible, correct?
That is correct.
And go ahead. I was just going to ask, what do you do with folks that are not Medicaid eligible?
So under our CRT structure, we do have a little bit more flexibility. We're required, of course, to support people to access the health insurance for which they're eligible, but in that structure, we can more flexibly serve people who might be funded or who might be receiving medical services through Medicare or VA, for example. Through fee-for-service, we do need to have people eligible for Medicaid, so we support people to sign up for Medicaid through, currently have a health portal, and if people do not qualify for Medicaid, oftentimes we are supporting them in doing a spend down so that they can qualify for Medicaid, or we do have a structure by which someone could self-pay for their services on a sliding fee scale depending on their income.
And in the fee-for-service environment, one of the things that we hear quite a bit is that the rates are set so low so as to make the actual reimbursement for the service that you're providing almost meaningless in many respects. Is that true in your environment? And if so, how?
It certainly is a balance depending on the type of service that we're providing. For example, we always lose out on our psychiatry services because the reimbursement rate is so low compared to what you would have to pay, to contract with any given psychiatrist.
Right.
What we've done with the Department of Mental Health is we are receiving, funds that are targeted towards fee-for-service billing, some that are targeted to CRT, and then we also have a small portion of grant funding that allows us to be a little bit more flexible and overall to, fund and sustain the program and services, particularly for the things that can't be reimbursed but are necessary parts of your day, like documenting your work or completing service plans or all of our administrative services.
Right. And since you have been transitioning off of the SAMHSA grant, what have been sort of the most challenging issues that Pathways Vermont has had to deal with in the transition to sort of picking up and starting to bill Medicaid for services? And are there things that you wish you had done differently to prepare for that transition?
I would say that the biggest challenge has been a cultural adaptation. Housing First as a model is intended to be very, very flexible. And because it's so flexible, we get the pleasure of working with people who might not walk through a medical model door. Right. So with Medicaid funding, we had to look at how do we adapt this program to still be the flexible Housing First supports that we need, but also be able to sustain ourselves. One major challenge that we encountered is that in order to bill Medicaid for services, folks need to meet annually with a psychiatrist and receive a diagnosis. That's not something that we had to do under grant funding, and it allowed us to work with people who, were really hesitant to engage with the medical model at all or to talk with a psychiatrist. So we had to think about a way to adapt our approach so that people could understand why we were asking this, what we were going to do with the information, and how it would ultimately lead them to receive services through Pathways.
And were there smaller challenges that were, and quite honestly, I mean, that's sort of like an obvious challenge, right? Here's this sort of very low barrier model in a very structured sort of Medicaid reimbursement kind of world. Even on the agency side, perhaps, there was adaptation that needed to happen because any kind of billing, documentation, all of that stuff is audited much differently than, a grant from a local foundation or perhaps something from, your local county or something like that.
Yeah, definitely. So we also had to develop systems. We were lucky in that we were already using Foothold as our electronic health record, and folks were already writing daily notes, recording their conversations and interactions with folks that we're serving. We had to train staff to tweak their notes to actually meet the Medicaid requirements in terms of billing. We had to train staff on what needed to be in place in order for a client to be billable. So, active Medicaid insurance, that annual meeting with a psychiatrist, an active signed service plan that meets particular criteria. And then we had to learn ourselves how to have the Foothold system talk with our Medicaid portal system. So all of those were challenges. And for Pathways, it was a lot of pioneering. We're the first agency to have been awarded this specialized service agency status in the history of the Department of Mental Health system of care system, about 30 years. So nobody else could really walk us through or say, here's what you need to do, here's how you get online. And that was a big challenge.
Yeah, that's phenomenal. You guys are trailblazers. For real. So, one of the things that, people spend a lot of time thinking about is the future. And, we're hearing all kinds of different things in the media, I think, depending upon which media you listen to. But the future of Medicaid is sort of a big question. So I'm not going to put you on the spot there. But in terms of the future of supportive housing, what do you see perhaps changing, or what would you anticipate having to change to address some of the challenges, I guess, that supportive housing providers have bumped up against, whether it's the scarcity of actual affordable units, acceptance of the model in your continuum or in your community, that sort of thing. Where do you see it going?
Well, I have to believe that the data is there, that working in this way, providing housing as a first step results in not only better quality of life for the people that we're serving, but also in significant cost savings through the taxpayers. So I have to believe that we're continuing this momentum in providing people with housing as a first step. One thing that I hope will change in the future is, again, right now, our Medicaid dollars are accessed through our Department of Mental Health. So everything that we bill for is through this lens of a mental health service. I think that there's a growing recognition that housing is in itself healthcare, and that it doesn't need to be necessarily contained within these siloed structures of the Department of Mental Health or substance use services, but that in and of itself, providing these types of services save the healthcare system money. So I hope that that will continue to change. Also, we know that there's a lack of not only affordable housing, so fair market rate housing available in our communities, but there's also a lack of availability of those subsidies that make even affordable housing affordable for the majority of folks that we're serving. So I also hope that we see increased development of affordable housing, and that we see the landlords and property management and housing trusts start to align their philosophy and their flexibility with the housing first philosophy, and maybe take a chance on folks that otherwise might have historically been screened out of being able to receive housing or support.
Right. I want to ask to follow up on your question about looking at housing through this mental health services lens as a result of how the Medicaid comes down to your organization. One of the things that we know is that emergency rooms are places where high utilizers of service spend. And that gets very expensive for healthcare providers. Have you been seeing partnerships in your communities between health systems and providers like yourself to sort of bridge some of those gaps, to do a little bit more collaboration, to decrease costs, that sort of thing? Have they stepped up yet? Have you been seeing that?
Yes, we have definitely seen that. Some of our biggest medical centers in the area have started to look to community-based providers to say, how can we support people to exit the hospital swiftly, right, as a first step, because swiftly is cheaper, and also safely. I think that the medical centers were also realizing that oftentimes they were discharging people to pretty vulnerable places or situations. So we have seen that, and we've seen some partnerships in that way. Our Department of Mental Health also has been administering a grant for the past couple of years that allows for the provision of some more flexible housing subsidy funds for people who are very high utilizers of the psychiatric care system.
Okay.
And that's a partnership that we've been directly involved with them.
Great. David, I like what Lindsay says about how saving the healthcare system money by extension saves all of us money. But I find that I hear quite a bit from providers that struggle with this whole transition to fee-for-service across the board, not just with Medicaid reimbursements, and that they're really struggling to meet their bottom line. And we've seen, I know, organizations close their doors, others get absorbed into larger entities. What are you hearing about the future of different reimbursement scenarios?
Well, CMS has been pretty clear in the last couple of years about their interest or their drive towards having alternative payment models, and primarily value-based payment models. I think there's a recognition on their part that many of the structures that they had put in place before had just promoted siloed care and promoted additional services for individuals so that people could generate the revenue necessary. And so I think what we are going to see more of is this concept of paying for the value of the service that is being provided, and that may be through managed care entities, that may be through a health home care model or some preferred provider network model. But I think what we're going to start to see is more and more value-based payments. CMS has set some goals for themselves about, by the end of next year, 50% of the money that is given for healthcare services through their entity would be based on value. So I think that's one thing, Paul, that I think we're going to see. And I think, part of the issue is that people are not only going from grant-based into either managed care or a fee-for-service managed care model, but now all of a sudden they're being put into these value-based pieces that, quite frankly, require you to have information. And you need to know the cost of your services. You need to know the structure in which you provide your services and the policies that drive those services so that you can manage based on that value. And as one of the positives of any reimbursement model for this field, and it's something we've known, probably everyone on this call, for a long time, is that the social determinants of health, housing is one of the most critical. Safe housing is critical to the recovery of any individual.
Right. Yeah, it'll be very interesting to see where it all goes with value-based payments as that ramps up further. So we've heard from a New York City-based provider. We've heard from a rural Vermont provider about their experiences. We also talked to Kevin Martone, who's the Executive Director of TAC, the Technical Assistance Collaborative. And TAC's an organization providing policy leadership, technical assistance, and consultation services in the areas of healthcare, affordable housing, and human services in communities across the country. Let's listen to what Kevin shared. How are traditional services providers still providing services and incorporating sort of more medically based services and the providers that are providing them, frankly?
Yeah, it's a great question because, I would imagine, like, in your audience, right, you have a whole range of providers who are doing some type of supportive housing. And they're probably like, how does this relate to me? And the landscape of providers all over the country is different. I mean, you have some very small, providers who are doing supportive housing. And you have some very large providers who are doing specifically supportive housing, or who may be a large community mental health center who's also doing supportive housing, and they have this capacity. And I think, the one thing to consider is that, not everybody should necessarily take on the burden of becoming a full-fledged Medicaid provider. It just may not be realistic. A smaller provider just may not have the size and capacity and infrastructure to go down that road. But nevertheless, the state system may be pushing providers to do Medicaid, right? And so what do? And I think what we've seen in states across the country is you've seen these partnerships develop, right? So how can a small supportive housing provider maybe link up with a large community mental health center that has a track record of delivering Medicaid reimbursable services, and how can they partner up to either, deliver those services in partnership, or really clearly identify the roles where maybe, the supportive housing provider provides some of the basic non-Medicaid tenancy-related supports, and the community mental health center provider takes on some of the more clinically oriented services that they can bill for Medicaid. And so it really depends on, those local relationships and partnerships that can be developed, depending on where you are and what type of provider you are.
So I think that your statement about, it's the taking on the burden of becoming a Medicaid provider isn't sort of the right move for a lot of organizations. In the work that you're doing across the country, are you finding that agencies are coming to that realization easily, or is there sort of ego involved, if you will, and it takes a little bit more to encourage folks to sort of stick to what they know and to partner with people who, have that level of sophistication to bring Medicaid into play?
It's a great question. Well, whether ego is the right word or not, I don't know. I mean, there was a provider who I was working with in a very large rural state, who was feeling pressure to move towards the Medicaid end of the world, and was really trying to take it on. And it was a huge struggle for them. And what I found them doing was they were starting to, because of those pressures, starting to overestimate the number of, or the amount of Medicaid revenue that they could pull in, which was actually then putting them at some risk, right?
Yeah.
And so what they ultimately decided to do was back off a little bit and really work in partnership with a larger community agency that had done, had more of a track record with Medicaid, to try to really work it out that way. And for them, that was the best situation. Other folks have really decided, well, if we're going to do supportive housing, we also may find value in providing other types of services, outpatient services or things like that. And they see it as an opportunity maybe to actually grow their business even beyond just supportive housing. So it can go different ways depending on, who you are as a provider, but also really thinking about, a business plan. What kind of business plan do you want to develop, and how do you go about achieving what's in that business plan, and that may or may not include, you know, some significant incorporation of Medicaid revenue.
You mentioned the MCOs. So they get health care, they get outcomes. How well do they understand serving this population, and how well do the service providers that have, you know, sort of historically been in the, you know, in that sort of like, let's just look at the homeless for a second, in the homeless services community, how well do they do translating what's happening within their organizations to a language, I guess, that the MCOs understand and that makes sense to demonstrate success in these programs? Is it just about somebody staying in housing, or is it also about staying in housing and reducing costs, which tend to be a large focus of the MCOs?
Yeah. You know, from the managed care perspective, it is somewhat of a learning curve. I mean, the managed care companies, the Medicaid managed care companies are taking on increasingly complex populations, right? And those populations can cost a lot of money when they're not getting the right types of services. You know, you'll often hear about high-cost utilizers or super utilizers. Those are folks who are, you know, in and out of emergency departments and inpatient units. And so to the extent that the states are putting the risk on managed care organizations, they have every incentive in the world to try to save money. And, you know, the balance there is, well, if they try to save too much money and cut costs, then it can backfire against them. But the managed care companies, I mean, they're increasingly serving that complex population. There's somewhat of a learning curve, you know, regarding it, and they have to be open to these other things that are sort of beyond healthcare, right? These other social determinants of health that you increasingly hear about, things like housing and employment, and what role can they play in ensuring that people, you know, get access to housing, stay in housing, get access to employment, stay in employment, because at the end of the day, that's going to positively affect their bottom line. Right. You know, from the provider perspective, it's a change, right? So if 20 years ago they were just relying on a sort of a loosely tied grant-funded program, there were less strings attached. Now, they're much more accountable. There's much more risk or skin in the game for providers when they're getting Medicaid managed care dollars to perform, to produce certain outcomes. And as managed care companies start to move towards, you know, value-based purchasing and things like that, providers are really having to learn sort of a new way of doing business. And, you know, that's a learning curve for providers. And sometimes the bigger, more sophisticated providers who've sort of been in this game for a while are more likely to succeed at it, you know, compared to some of the smaller folks who may be new to the game. You know, it is a struggle for them to sort of adapt in that environment. But that is definitely a game changer sort of going forward. You know, it's not just about, you know, when we looked about it from a supportive housing perspective, you know, sort of the basic services and housing, you know, managed care and healthcare in general now is looking at, you know, paying for outcomes and positive measures and really integrating sort of, you know, overall health. You know, it's not just about mental health. It's about mental health and substance use disorders and physical health care, and really tying all that together. You know, when I was doing supportive housing, you know, early on in the 90s, and basically right out of college and sort of a, you know, basic mental health worker, I always thought my job was to basically, you know, get people to take their medications, keep them out of the hospital, and get them to admit that they had a mental illness. And that was wrong. It doesn't work that way anymore, right? You know, it's very much now, you know, having people, you know, whether a person admits that they have a mental illness or not doesn't really care. It doesn't bother me, you know. And frankly, if a person's not totally compliant with their medications, but they're doing what they need to do in the community, and they're maintaining their apartment, and they're staying out of trouble, and they're working, you know, those are the things that are important. And, you know, so the system's really changed and evolved to that. And, you know, I think the states and the managed care companies are really just trying to look at those outcomes and bottom lines versus sometimes our own stereotypes of what should be, if that makes sense.
It does. So when you talk about the social determinants of health, and there's been a lot of that, you know, that it's folks who've never heard the expression before, I feel like are using it now with frequency. Does that sort of lead the way into, so housing, keeping people well. It's important to stay safe and warm and dry and, have connections to community and all of those things that housing bring us. Is it also a way, this dialogue, does it help to bring more into the Medicaid fold, or no? So for instance, do you think, we mentioned education, you mentioned employment, I mean, all of these things are, sort of been identified as social determinants of health. Does that mean that they're medically necessary and therefore something that Medicaid could ultimately become the catch-all provider for, or does it stop somewhere?
I think the jury's still out, right? So Medicaid directors are very much so and increasingly interested in what supportive housing has to offer. And they're seeing the research, they're seeing the evidence, and they're saying, hey, a lot of these services are services that we already cover or we could cover, and we think that's going to help us bottom line, right? So in one respect, absolutely. When you start to get into some of the things that are a little bit more specific to housing, some of the very specific tenancy support services, or sort of your case management staff coming in and doing X, Y, and Z to, prepare the lease for the individual, or, pay the startup costs for an individual, that's where there's, I think, some hesitancy within the Medicaid world and CMS on paying for those services. And then when it gets over to, you hear some, like we talked earlier about sort of suggesting, well, can Medicaid, if you're thinking it's a social determinant of health and you tie it to health care, why shouldn't Medicaid pay for housing then? That's where you're really stuck. I mean, partly you're stuck as a statute, but partly you have folks, in Congress or not in Congress, but folks who are sort of policy wonks who sort of say, we understand it, but at the same time, there are a lot of people in states who don't have access to Medicaid to begin with, right? Or the benefit packages are so skinny in states to begin with that, if we have any savings within Medicaid, shouldn't we get more people access to Medicaid, or shouldn't we make those benefit packages a little bit better for folks on Medicaid rather than going to pay for actual housing for folks who already have Medicaid? Arguably they need it. It's not necessarily debated whether they need it or not. It's just what's the best use of Medicaid dollars, and at the same time, are you letting the HUD and the housing folks off the hook by saying, well, we'll just have Medicaid pay for it? That's sort of the crux of the conversation that goes on out there.
Right. I mean, because I feel like, over the years, I mean, HUD has made a pretty concerted effort to get out of to start to get out of, they've been talking about it for a long time, funding services, frankly, because they really wanted to support housing, and wouldn't services be better, funded elsewhere? So, yeah, interesting to hear that could potentially be the same kind of conversation that would happen in the sort of Medicaid environment with CMS.
It is, exactly, right. Yeah. HUD looked at how much money they were putting into services, particularly sort of in the McKinney supportive housing program, right, and saying, shouldn't those services be paid for by Medicaid or state mental health authorities, for instance? And then then you sort of fast forward, and you had mentioned earlier, and maybe I'm sort of getting ahead of myself a little bit, but when you sort of look at the climate down in D.C. on what it looks like for Medicaid and HUD budgets, there's a lot of concern, right? So you potentially have, if Congress moves to push Medicaid out to a per capita or block grant type of program, ultimately down the road you'll see the amount of money that goes to serve people, Medicaid eligibles in states, and what types of services or benefit packages they have. You'll see that money decrease over time because states are basically capped at what they have, and the cost of health care and things like that will essentially outpace what they have to spend. And so, thinking down the road, I think there is some concern about ultimately, hey, what does supportive housing look like for folks? I mean, some folks who are probably our most seriously disabled or have the most serious, chronic health conditions, they may be chronically homeless and have really serious health conditions. Those folks may be fine. But, when you think about supportive housing is a model that can really serve a broad-based population. And, the more significantly compromised folks will probably still get those benefits. But folks who traditionally weren't eligible for Medicaid, who we could argue, should be eligible for Medicaid or, could really benefit from services and supportive housing. For instance, people with substance use disorders who weren't traditionally eligible for Medicaid. Those folks might lose those benefits going forward, and that would diminish, how broadly, you can apply a supportive housing approach to, populations who arguably could benefit from it.
So this has been great information. I think the takeaway from all of these conversations are that supportive housing is a model that works, and using Medicaid to fund services makes sense. And the pressure onto providers to gain administrative sophistication and to seek partnerships with other organizations in their communities isn't likely to go away anytime soon. So, David, can you run us through what the world of Medicaid compliance looks like and tell us about how providers are expected to step up to meet these more stringent requirements?
Three of the major pieces of Medicaid that I think jump out at you as during our conversations. And obviously, Medicaid's a very complex piece of work that people are going to have to live with. But three areas that are very important. One is the workforce. Second is around documentation. And the third's around administrative requirements. And we'll talk a little bit about each of these if we could. So on a workforce, you really have to have a workforce now that meets the regulations, right? Along with Medicaid often comes various regulations around what staff can supervise and in some cases what staff can work in a program. And so you have to review your workforce in relationship to those regulations. You also are going to have a different skill set. I mean, not the least of which is the fact that you are going to be required to keep different documentation that you may have kept before. And so you're going to have staff that have the ability to do that documentation. And in some cases, you're going to need staff that have the ability to do that documentation in an electronic format. The culture of your workforce oftentimes in a Medicaid environment can get transformed into more of a medical model or more of a payment structure model, and we don't want that to happen, and obviously you don't want that to happen. And so there's really a need to make sure that you retain the culture of who you are, but yet you recognize the fact that there is the culture that this program is based on federal regulations, and the services being provided are oftentimes have to follow those regulations. Things change very quickly in the Medicaid world. And so the adaptability of staff and the adaptability of administrators is going to be very important. And I think one thing that you're starting to see and is going to become more and more prevalent, and as we talked earlier about value-based payment, is that we have an information-driven system. And that information is going to be used more and more in both the decision-making process, but also in the reimbursement structure process and the rate-setting process and other areas. And so having the ability to understand information is going to be very critical for your workforce. Documentation is, a very interesting part of what Medicaid brings with it. Except when you're doing documentation, there is some things that we have to make sure are in place. For example, you have to make sure that the recipient's choice of goals are being met. All documentation now, and in fact, anything that you see out of CMS recently talks about person-centered planning. And so you want to make sure that your documentation is reflecting that individual's perspective of what is happening in your program. You want to make sure you meet federal regulations and state regulations. It's going to be very important that your compliance around these is 100%, or if not 100, at least is 99.9%. And the fact that you'll see more and more of this infusion of evidence-based practices, and that your current practice values are reflected in your documentation and you follow the guidance that's given to you. documentation for many reasons has been sort of misunderstood as a why do we do documentation? You know, yes, it is for the purpose of meeting regulatory requirements, and that is very true. It's also important from a plan of action perspective. The documentation you create is really a reflection of that individual's growth within the service that you're providing. Documentation provides support for billing, critical in this environment. It's going to provide information for your decision-making process. This data becomes information which you use as knowledge to make decisions. And very critical in a managed environment is this idea that you're going to have that you're going to meet these medical necessity standards that are in place. From an administrative perspective, Medicaid brings with it an awful lot. Maintaining state and federal compliance, making sure that Medicaid billing is being met, making sure that your workforce is developed in a manner in which it meets the standards that are set forth by Medicaid, but also in that you can operate your program. You're going to have to maintain records. You're going to need to have a quality improvement process, and there will be some additional reporting requirements that are there. And so the world of Medicaid brings a lot of things with it. But I would like to say that there are opportunities. At least we hope there's opportunities that are going to come forward with Medicaid funding the kinds of services that are going to help people have independent housing options and supported housing environments. So Sarah, I think if we can open it up for some questions.
Yeah, absolutely. We just have a couple minutes left. But if you do have a question, just send it to Foothold Technology through the chat or the Q&A feature, whichever you can find first. We can answer a couple of those. If you don't have questions or you don't feel comfortable asking them on the WebEx, here's the contact information for both Paul and David, and they'll be happy to, at any point, just receive an email from you to address any questions you might have. So I guess we'll give it a couple minutes and see if anything comes through. So while we're waiting to see if there's any questions, I just wanted to thank everyone for joining us today, and to thank Lindsay, Kevin, and Steve for participating in these conversations with us. The conversation always continues on our Supportive Housing Resource Exchange. This is an online forum we've put together for supportive housing providers across the country, where providers can pose questions and provide resources for one another. We most recently had a kind of in-person resource exchange at the Corporation for Supportive Housing Summit in Denver, and we saw quite a bit of activity and great feedback on that. The Resource Exchange is part of our Supportive Housing Resource Center, which is kind of a broader center for resources that provides podcasts, articles, videos, blogs, and webinar offerings for the community. Those conversations with Steve and Lindsay and Kevin were just clips of the full conversations we've had. So we are going to post the full conversations on the Supportive Housing Resource Center in a day or two. We have the links to the Resource Center showing on screen right now. It will also be sent to all of our attendees today in a follow-up email, along with a full recording of the webinar. So let's go back and see if there are any questions that came through. Okay, so it looks like we have a couple here. For the senior community, what information is available for providers? In relation to housing and services, using Medicare, SNPs, or other type of payers?
David, I think you probably have the best perspective on this.
Yeah. Are they asking for what information is available? Sarah, is that what the question?
Yep, that was the question.
All right. There's a number of different documents that have been published that talk about different strategies for various populations, including seniors that are in housing environments. I think we probably, I don't have a way that we can put a link up right now, but I think, Sarah, we could send folks a couple of links to some documents that might be able to provide them with some additional information.
Sure.
Okay.
Okay, great. And then a next question we had is, what is the best way to get started in this program? Does it take a year to be up and fully running?
Well, I think a lot of that's going to have to depend upon the state that you're in and the funding opportunities that are available. There's a number of states right now that have funding available to increase their housing, especially their supported housing efforts. I think from an operational perspective, and Paul, I don't know if you have a different thought on this, but you are looking at a period of time from when you apply for a state grant until you can get all your pieces in place and operational. And I think as a number of the speakers talked about today, it takes some time to get up and get your program operating at full effectiveness and efficiency.
Yeah, I agree. I don't have much to add to that because it's really about where you're starting, and that sort of drives how long it will take to get where you're going. So with some more information, we might be able to tease some better answers out. But I think that you might also find some information on the Supportive Housing Resource Center through the link that Sarah has up on the screen, because I'm certain that has come up in the past.
Yeah, and Sarah, if they send an individual email, so we know what state they're in, it'd probably be a little bit easier for us.
Okay, yeah, sounds good. One more question I think we have time for, and then we'll wrap up, and that is, are there companies who will assist in the analysis and implementation of Medicaid reimbursements?
I'm not exactly sure what you mean. If you're talking about analyzing the revenue that you could expect to generate and building a program model, or the actual operational requirements around billing Medicaid and in a supported housing environment, or the actual billing of Medicaid. The last one, obviously, those of you who know us understand that we do direct billing. The other two areas, there are a number of different technical assistance centers that are out there that do provide help to providers about entering this kind of a field, or helping providers trying to move into the Medicaid world.
Okay, great. So I think with that, our time is officially up. So thank you to Paul and David for guiding us through this conversation. Thanks again to our external presenters, and for all of you participants today.
Thank you. Thank you all.
Yeah, thanks everyone.